So Dr. Chandrima will be talking on intraocular pressure measurement and concept of target IOP.
Thank you, Dr. Chakravarti. Once again, a very good morning to you all. And in the next few minutes, I'll take you through intraocular pressure measurements and the concept of target intraocular pressure. So the importance of intraocular pressure is the main risk factor for the development and progression of glaucoma. Lowering intraocular pressure decreases the risk of progression. Protective effect of IOP is definitely dose dependent, and all stages of glaucoma, starting from ocular hypertension to early and advanced glaucoma, benefit from IOP lowering. But having said that, I would like to say in broad capitals that high intraocular pressure is not primary open angle glaucoma. There are a lot of other factors before you label a patient as primary open angle glaucoma. So the factors that influence intraocular pressure, you can see a lot of them that you have in our day-to-day activities that actually influence intraocular pressure. And because of these factors, when you measure intraocular pressure at your clinic, you need to be aware that under what circumstances you're actually measuring that pressure, because that pressure could actually fluctuate over maybe 10 to 12 millimeters of mercury. So making sense of IOP fluctuation on that note is nocturnal rise of intraocular pressure, which has to be on your minds when you're measuring intraocular pressure. That's the worst time of the day for health. As you know, overnight blood sugar levels rise, blood pressure, body temperature, and heart rate becomes slower, and eye pressure is at its highest. So factors that influence intraocular pressure, body position. If you look at, there isn't a point out here. So if you just look at these symbols which are there on the right, this shows the positions, and according to that color is here the scatter graph, which actually very clearly reveals to us that how the position of the body actually changes the intraocular pressure. Next come factors that influence intraocular pressure, the eye movements. So if you have a look at these eye movements that you see out here, we have a graphic representation which I'll show you in a moment's time, and how they actually change intraocular pressure. So these studies were all done in the Hamilton Glaucoma Center by none other than Professor Wenreb. And look at this, how it actually influences intraocular pressure. Look at this gaze and look at the IOP out there. Look at this gaze, look at the IOP out here. So the gaze of your patient when you're measuring intraocular pressure is very important. To get the optimum intraocular pressure, you must ask your patient to look straight forward, neither up nor down or either ways. Next, we have activity. You'll be surprised to know how activity actually influences intraocular pressure. Just look at that. Resistance training, any kind of band push-up or weightlifting. Look at the, could I have a pointer please, if there is one? But just look at this. The cursor out here is not working very well. So just look at this, where the intraocular pressure goes with resistance training. Next, we move on to walking and cycling. However, during walking and cycling, look how intraocular pressure actually comes down. That's 30 minutes post, 60 minutes post, and 120 minutes post. Next, we move on to meditation and yoga. So this is actually a pretty controversial thing, because meditation does improve intraocular pressure, but certain yogas actually do lower intraocular pressure, but there are other yogic exercises which actually are detrimental to intraocular pressure. And this is alcohol consumption, which lowers intraocular pressure. So the factors that influence IOP, seasonal pattern, that's very interesting. If you have a look at both of these graphs, I'm sorry, I'm just hovering around out here because the cursor is not working always. So look at this and look at this. So if you see that in mid-winter, there is a rise. And again, if you look at this mid-summer, there is a fall. That's almost about 7.1%. That's better, thank you. Next, we move on to the tonometer types. So the tonometer types we have, you all know, you'd get it in the books, internet, everywhere. Indentation tonometer, applanation tonometer, pneumatic tonometer, non-contact, and contour matching tonometer. So if I move any further, I would say we would concentrate on this, that is applanation tonometer. That's still the gold standard for intraocular pressure measurement. Pneumatic tonometers are when you have some kind of a corneal problem and you need to measure the intraocular pressure, and non-contact tonometers are really not that reliable, and definitely we don't use them to guide us in progression or disease at the glaucoma service. And contour matching tonometers, well, we did a lot of the DCTs, say about 5-8 years back, and we have studies on those also, but somehow they have not lived up to the expectations that they came with. So use of tonometers, pneumatic tonometers, as I told you about it, useful in eyes with diseased or irregular corneas. Pneumotonometers and tonopen can measure IOP through bandage contact lenses, and tonopens are favored. Actually, the studies show that tonopen does compare very favorably with Goldmann applanation tonometer. So the current gold standard, as I told you, is the Goldmann applanation tonometer, and you know that it applanates the cornea and the measurement of force required to flatten a fixed area of the cornea. That's the principle on which it works. And Goldmann and Schmid actually acknowledged that a variation of the central corneal thickness would influence the IOP readings, and almost using Goldmann tonometer for about 50 years. After that, we started correcting it for the central corneal thickness, and it's the Goldmann and Smith algorithm actually centers around the 520 micron. That is actually the corneal thickness at which the tonometer needs no correction. Otherwise, you'd have to connect it either ways. So this is again the same thing. And applanation tonometer on thin corneas would mean underestimation of the IOP, and thick corneas would result in overestimation of intraocular pressure. So that's actually a rough graph. We really don't have any proper algorithm where you can actually, by the rule of law or by mathematics, get an exact measurement of the IOP. But generally what we follow is 70 microns change in CCT corresponds to 5 millimeters of mercury difference either way. So measuring the intraocular pressure with the Goldmann applanation tonometer, I'm sure you're aware of it in your clinics. You anesthetize the cornea. Fluorescent sodium is a prerequisite, remember that, because that only gives you the correct Myers with which you can actually measure the intraocular pressure. Slit lamp illumination, arm positioned at an angle to the observation arm and brought closer to the eye till corneal contact is made. A biprism within the tonometer tip splits the image as seen in the two semicircles that you see out here. And the height, you should adjust your slit lamp that the height of both these semicircles should be equal. And there's a dial on the side of the tonometer which is fixed at 1, and then you move on your slit lamp for the instrument, the prism, to touch the cornea of the patient very lightly. And this causes a movement of rings towards each other. These rings would be far apart when you're far away, and then there comes a point where the two rings meet. And this is exactly the end point. That is where the two Myers, the inner edges, meet, and that you multiply by 10, and that would give you the intraocular pressure. Well, the Goldmann applanation tonometer needs to be calibrated, and at least once a month at your clinic, you should calibrate the Goldmann applanation tonometer. Just a little bit about intraocular pressure and anesthesia. So chloral hydrate is the perfect anesthesia for measuring intraocular pressure. Halothane reduces it, ketamine increases it, and of course endotracheal intubation increases it. And on that note, I'd like to say that the Perkins handheld tonometer is the best that one can use as an ambulatory tonometer and under anesthesia for if you're actually examining a child under anesthesia or performing a trabeculotrabeculectomy. Next, we move on to target intraocular pressure. So target intraocular pressure, the American Academy says that the goal of treatment is to maintain the IOP within a range at which visual field loss is unlikely to substantially reduce a patient's health-related quality of life over his or her lifetime. The estimated upper limit of this range is considered the target pressure. That's from the American Academy, and the European Glaucoma Society says that the estimation of the mean IOP maintained with treatment that is expected to prevent further glaucomatous damage. So it's individual, dynamic, and a modifiable parameter. If glaucomatous damage occurs under these IOPs, then you need to actually shift your target IOP. But as a bottom line of target IOP, it's that pressure at which there is no progression. So these are the golden words for target intraocular pressure. So the rationale for target intraocular pressure is IOP is the only modifiable risk factor, as I told you, that affects the progression of glaucoma, though there are other lifestyle changes which you can advise to your patients. Different individuals respond differently to the same level of intraocular pressure and necessity to establish the target IOP for every single patient that you treat in your clinic. So factors that influence target intraocular pressure are race. African Americans show higher prevalence of glaucoma than Caucasians do, and African Americans show earlier onset and progress to blindness more frequently. So the associated ocular and systemic diseases, these are actually more of book knowledge. You can read them up, but just to cover up, it's pseudoexfoliation, systemic hypertension, antihypertensive medications, and diseases that interfere with life expectancy will influence target intraocular pressure. And by that I mean that if a person is going to live longer, you need to have a lower target IOP than a person who's going to live shorter. So the risk benefit of treatment, the impact of treatment, and the quality of life needs to be taken into account. So again, baseline IOP, it is important that the first IOP at which glaucomatous damage occurred, you need to know that baseline IOP if possible. Central corneal thickness, I've just spoken to you about it, so you know about it. And a point here is that the eyes with lower corneal hysteresis are more prone to progression. That is in various studies which were conducted. Factors that influence target IOP, again, severity of disease. What we do, if you look at this on your left-hand side, age of disease onset, that's death, and severe functional impairment, you would see that life expectancy and target IOP have a direct relation when you set your target IOP, and the greater the life expectancy, the lower the target IOP. The rate of RCG loss, retinal ganglion cell loss, age at disease onset, physiological loss of the RGCs. There are instruments now which can actually give you the RGC loss at that particular age due to age or due to disease. And glaucoma accelerates the rate of loss, and slow in most patients, but fast in a few. So estimation of target IOP, let us have a look at this. We actually estimate it on the severity of glaucoma, which we divide into mild, target IOP around 18, 16 to 20. Recommended minimum reduction from baseline is 25%. In moderate glaucoma, it's around 14 to 18. Recommended is 30%. And in severe glaucoma, it's to bring it down to around 10 to 14, and the recommended is 30 to 45%. So that's the buzzer. Yeah, just another few slides. That's if you look at this, safe sight years, they call it, and this was devised by Anders Hale and Brandel from Allergan and Zeiss together. It's a very informative graph that they've done. So if the glaucomatous damage is early, higher target IOP. If it is advanced, then lower target IOP. If life expectancy is short, higher target. If it's long, then lower target. Untreated IOP, higher target, lower target. Additional risk factors, no risk factors, higher target IOP. Additional risk factors, lower target IOP. And rate of progression, if it's slow, higher target IOP. And if it's fast, then it's lower target IOP. So that's a very simple way to actually set your target IOP. So routine continual IOP monitoring improves management, enables sustained relays treatment, improves adherence to medication, and plethora of data, which is a deeper insight. So IOP is not conserved from day to day. IOP behavior at specific times on a given day does not improve meaningful information regarding IOP at a specific time. That I just showed you at the beginning of my talk, how actually activity and everything else can influence IOP. So glaucoma is perhaps more multifaceted and less understood than all other eye conditions, given the ocular, vascular, and neurological involvement that it has. Much confusion stems from glaucoma being neurodegenerative, having vascular etiology, yet only IOP being commonly discussed and treated. Thank you very much for your attention.